This conference will now be recorded.
Hello, everybody. Thank you for joining us today as we introduce our new Lurie children's plastic surgeon, Dr. Jennifer McGrath. Dr. McGrath comes to us from Children's National Hospital in Washington, where she did her fellowship in pediatric craniofacial surgery. We're so happy that she's here with us. She's going to be seeing patients out of our main hospital, Northbrook, Lincoln Park, and our new Skokie location probably around January. So we're very excited about that. So, oh, I see Dr. Gossain just joined us. So one moment, Dr. Gossain, I'll send it over to you. But I just wanted to mention that, as I said, Dr. McGrath will be seeing patients out of our new Skokie location in January, but Skokie opens up on Monday. We started seeing people for audiology and for allergy, I believe, today. But everything else pretty much starts on Monday. So we're very excited about that. And if anybody needs any additional information about Skokie, please reach out to me. But from there, I'm going to go ahead and send it over to Dr. Gossain, where he can talk a little bit about his department and Dr. McGrath. So take it away, Dr. Gossain.
Yes, well, thank you all for being part of this session. And our division has been part of the plastic surgery, or part of Lurie Children's for as long as Lurie Children's has been here. I've been the chief for the last 8 years, and we have, during that time, I had the pleasure of being part of Dr. McGrath's training. She was a resident here at the Northwestern program, spent a year with me in the lab focusing on research related to helping children with congenital anomalies. Did an excellent job. Went on to do a fellowship at the Washington National Hospital in a very reputable system for a cleft, craniofacial, and pediatric plastic surgery. And we're so delighted that she's joining us here and able to serve you in a lot of these satellite communities, including Skokie. So I'm going to turn it back to Chad and to Dr. McGrath.
Oh, thank you, Dr. Gossain. That was a wonderful introduction. And I don't have much more to say. So, Dr. McGrath, why don't you go ahead and take it over, and I'll run the slides for you. I'll stay on mute, and I'll also look at the chat room as well. Thank you.
Great. Thank you so much for the introduction, and hello to everyone out there. I know that times are strange right now, so this is my first time presenting to a group of providers over GoToMeeting, so hopefully no glitches, but I'm happy to answer any questions. And this is just a brief overview of some common things that I'm seeing even in just the first 4 or 5 months here in practice. All right, we can start. So I'm going to focus on the two main first topics as macromastia, or enlarged breast hypertrophy, and then also talk a little bit about gynecomastia, because those are the two things that I'm seeing a lot of those for right now. And then also at the end, I'm just going to briefly talk about a couple other conditions, more just to put these in your heads as you see your patients in clinic, especially your adolescent patients, just to start thinking about referrals so that you can identify some of these more rare things if you see them and get them referred to us in a timely manner. So next slide. Okay, so I'm going to start with the most common thing that I'm seeing right now in terms of pediatric breast, and that's macromastia, or breast hypertrophy. And I'm seeing a lot of patients that are coming in anywhere from age 14 up through age 18 presenting with the common symptoms of enlarged breasts, and that's typically back pain. That can be back pain in the upper or lower part of the back, and shoulder and neck pain as well. So usually that's their main complaints. More rarely, they can have even neuropathic symptoms, and those are more common in the ulnar nerve and the median nerve distribution. It's not as common in the younger kids, but it's definitely something to look out for as a primary care provider. We also see other features on exam, like indentations or even ulcerations in the shoulders from indenting from the bra strap. So we call that shoulder grooving. It's something you might see on a physical exam. And you can even have irritation or ulceration of the skin there. Other things that are pretty common that might come up to you in your consultations with your patients are intertrigo or even hidradenitis. So rashes between or below the breast, that is often a common complaint. We also see functional limitations related to macromastia that can include activities such as lifting or running or interfering with sports. And a lot of young women really have difficulty participating in activities that require a lot of physical activity because of the size of their breasts. And then also, which is always in the forefront of our minds, is how this is psychosocially impacting our patients. And that can be a wide range of things. So we commonly see patients being very shy, attempting to cover up their bodies, having issues with gym class. We also see issues with unwanted sexual attention in our young women, which can be quite distressing to them, and even a lot of issues with cyberbullying or in-person bullying that I've seen in my patients recently. So we definitely wanted to highlight that, even though it may not be something that comes up from an insurance company's perspective as a reason for surgery, but we see it all too frequently. Okay, next slide. All right, so looking at the benefits of breast reduction, this is very obvious to us as plastic surgeons. It's a big part of what we do, but just to reiterate to you guys, we see a lot of benefits to our patients for breast reduction. And classically, breast reductions are one of the surgeries that has a really, really high patient satisfaction rate. So anywhere from 80 to 90% of patients in long-term studies are happy that they went through with the operation, which is really high in terms of patient satisfaction standards. They see obvious symptomatic improvement in raw pain scores, in their functional capacity, and things like intertrigo improving. So those symptomatic things do improve with breast reduction surgery, and that's been shown in many studies. We have seen studies of the spine and posturing of the spine that can show objective improvement in spine posture as well. And we also see that even weight loss can be more successful in women that have had breast reduction. And this probably comes back to a combination of factors, but also that functional limitation that we see with women that have macromastia. Other studies have looked at things like body image improvement, the psychosocial aspects. There's been studies that show increased engagement in social activities, increased extroversion, and even some improvements in the presence of eating disorders in particular populations of women with macromastia. And there have even been studies that show that breast reduction surgery can increase work productivity, and that has to do with decreased time calling out of work, as well as an improved efficiency at work due to the improvements from surgery. So it's a lot of things that go even beyond just the symptomatic improvement from pain, and this has all been published in the literature. So thinking specifically about our population of adolescents, studies have shown that at least 80% of women with macromastia report that their symptoms started sometime around puberty during adolescence. So most women, even if they have breast reductions much later in life, report that they've been struggling with these symptoms since adolescence. So it's important in our patients to understand that this is something that's starting much earlier in life. And we do see that the incidence of macromastia is increasing, even in all women, but also in adolescents. And that's probably also multifactorial and having to do with, unfortunately, an increase in the average BMI of our younger patients, and also things like in earlier ages of menarche, as well as some people suggest exposure to hormones in things like their diet as well. But we do see that macromastia incidence is increasing. Outcomes from surgery for adolescents that are going through with breast reductions have been shown to be very similar to the outcomes of older patients that are going through with breast reduction. So they do see the same improvements in their functional capacity and in their pain scores that more mature women are experiencing as well. We often are thinking about doing an operation on a growing breast potentially as a risk for having a high rate of recurrence later in life, especially if the breast size is not stable when we're deciding to do a surgery. So any patient that comes to see us, we usually want to make sure that their breast growth is as complete as possible. And we usually do that by making sure that their bra size or breast size is stable for roughly a year prior to offering a surgery. And if we follow those rules, we typically see very low risks of recurrence in our patients, assuming that we're dealing with just adolescent macromastia and not something more rare like a juvenile gigantomastia, which is not a common condition that we see. And beyond that, we do see that our patient population of adolescents with macromastia do tend to have a higher average BMI than our older patients presenting with this condition. And this, again, probably comes down to the relationship with macromastia to obesity, but then also the contribution of precocious menarche potentially, as these things have been shown in studies to be risk factors for macromastia in adolescents in particular.
So Dr. McGrath, Dr. DeWong sent a question, and she was asking a great question. She asked, do you recommend the patients to lose weight first?
So it kind of depends on the individual patient. There are definitely, risks to surgery related to a patient's BMI. So it kind of depends on how high their BMI is. So usually if the patients are around 30 or under, I'm personally not recommending specific weight loss prior to surgery. There is a lot of evidence in the literature to show that weight loss can be very, very difficult and that it doesn't actually result in a meaningful improvement in the size of the breasts. So I usually recommend weight loss for the mitigation of some surgical risk, not for resolution of symptoms. But obviously weight gain can also increase breast size as well. So more than anything, trying to establish healthy eating behaviors, stabilizing weight, healthy, nutrition, things along those lines that really impact surgical outcomes. But there is literature to support that weight loss as a solution to macromastia is not successful. Does that answer your question? Okay, so this is from a study from Boston Children's Hospital looking particularly at adolescents that have undergone breast reduction surgery and just showing you an idea of the overall outcomes for things such as breast pain, back pain, and even some of the other symptoms like intertrigo, shoulder grooving. The blue bar is the preoperative scores, and you can see the incredibly high rates of pain, almost over 90%, close to 100% in some of those fields, and how they drop down to at the level of a control population or even a little bit below the control population post-operatively. So showing that breast reduction surgery has a meaningful impact on this symptomatology. And this is again from that same study showing that the drastic improvements in different domains of the SF-36, so quality of life, in pretty much every domain improved meaningfully except for the general health domain. And that is looking both at, this was significant looking at within individual patients pre and post-operatively, and then also the study showed that these domains of the SF-36 after surgery put them kind of within the range of a normal control population as well. So again, improvement in physical functioning, pain, social functioning, emotional functioning, and even improvements, although it wasn't statistic in this study, of the eating disorder 26 score. So this is something that is becoming more and more important to me as I'm really establishing myself in practice. As is true with a lot of conditions, especially surgical conditions, we deal with the insurance companies a lot about coverage for breast reduction surgery. So I felt like it was important to highlight this to you all, because some of these things are things that can be done prior to a surgical consultation to kind of check our boxes that we've tried conservative management for some of these patients. So to get a patient covered for breast reduction surgery, the insurance company typically needs to have clear documentation of the symptoms such as pain, intertrigo or grooving, as well as objective measures that their breasts are truly hypertrophied, and this is usually done by the physical exam. But they also usually require a failure of conservative management, and that's usually all of these things are required. So not just one or two of them, but usually all of them are required, including trials of physical therapy, symptom management with things like medications like NSAIDs, or hot and cold, and then appropriate support garments, which, as you can imagine, a lot of our young women are not used to wearing. And then usually along with this, we have to submit an estimate of how much we think we will take off during surgery. And there are scales that the insurance companies use to make sure that that's a medically necessary amount. So this is an example of how that medically necessary amount relates to body surface area and therefore weight. So as the body surface area of our patients goes up, we are then kind of required by this scale, which is called the Schnur scale, to resect an amount of breast tissue that is intended to make a meaningful improvement in the patient's symptoms. And they use this as a marker to kind of cut off between what would be considered cosmetic reduction versus a medically necessary reduction. So this, I just wanted to reiterate here, which is important for you all. So what can you do as primary care providers prior to a referral? So as was highlighted by that great question, encouraging healthy weight behaviors is important, which I'm sure you are all absolutely doing. But obesity itself is, or patient being overweight is not necessarily a contraindication to a referral for breast reduction or for going through with a breast reduction surgery. So that's important to know as well. Referrals to physical therapy, because it is such an important aspect of what the insurance companies often require, would be something that would be absolutely appropriate to do as a first step for your patients. And the insurance companies vary about the duration, but it's anywhere between 6 and 12 weeks of physical therapy. In addition to, I would absolutely recommend talking to your patients about finding an appropriate garment that usually has larger weight distributing straps that might need to be purchased either at a specialty store or online, that is designed for women with larger breasts rather than just the old normal Victoria's Secret bra with the narrow straps that might not be supportive enough. Topical medications for intertrigo can range anything from just topical drying agents like powders or antifungals if necessary. And usually if there is a rash present, the insurance company wants to know that it's been treated medically, or sometimes they will say that that needs to be done prior to going forward with the surgery. So if anyone has any questions about that, I could take them now or we could wait till the end, but I just had a few slides about gynecomastia as well. Okay, so I'll just go through this. So gynecomastia is probably the second most common breast condition that I'm seeing in referrals. And usually what we're seeing is obviously a pubertal gynecomastia, which is more of a physiologic gynecomastia. It's very rare for us to really see a pathologic gynecomastia, which is when it's related to other conditions such as thyroid disease, kidney disease, or gonadal failure, for example. So what we're typically seeing are boys between the ages of even 14 to 16 or 17 who are coming in with distressing amounts of gynecomastia. And there's no real cutoff for that. It's very individualized to the patient, as you can imagine. So the amount of breast tissue hypertrophy that's causing distress can be very different in individual patients. And there's no real cutoff that is the requirement for whether or not they should be sent to CS, because it is all very personal to the individuals. So we usually classify gynecomastia by grade, where grade 1 is a very localized amount of tissue hypertrophy, which is usually limited to the tissue just around the areola. Grade 2, this starts to extend beyond the areolar boundaries, but you can't really see a ledge between the breast tissue and the chest. Grade 3 is even more enlargement, where you actually have a boundary of tissue where the breast tissue can be visualized as separating from the chest wall. And then grade 4, we start to see a true feminization of the breast. And then we also see fairly frequently pseudogynecomastia in our patients, especially our obese patients. And that's really not a hypertrophy necessarily of the glandular tissue alone, but really more related to adipose tissue and a feminization of the breast from adipose tissue from an increased weight. So this is an example of a more severe case of gynecomastia. This is probably a grade 3. This child actually did have pathological gynecomastia related to an androgen insensitivity syndrome. So you can see that there's a distinct border between the chest border and the breast border, and you see a little bit of a shadow underneath the bottom aspect of the breast where you have some skin redundancy. So these are all things that we're looking at when we're seeing patients and trying to come up with a surgical plan. So the surgical approach for gynecomastia really depends on the individual. We commonly will directly remove the glandular mass that's below the areola. And we can also combine this with liposuction to create a nice contour on the chest wall so there's no obvious step-offs from where we've done the excision. Skin redundancy is a big factor, as you can imagine. Once we've removed the breast tissue, we do rely on the skin to contract quite a bit to create a nice contour of the chest. And if you have a lot of skin redundancy in a grade 3 or grade 4 gynecomastia, then a lot of times we do require excision of the skin directly, which for the kids is really important because it does put external scars on the skin as well. And then important to know for patients coming in that are potential surgery candidates is we do have activity restrictions after gynecomastia surgery to try to reduce some of the complications that we see, such as fluid buildup and bleeding. And those activity restrictions can be quite significant and go on for even months after surgery. So especially in these active adolescents, that can be quite prohibitive to them. And talking again about some of the not fun aspects of insurance company coverage, but gynecomastia is unfortunately one of those conditions that can be very impactful to our patients, but that a lot of insurance companies do not offer any coverage whatsoever for. And this really varies from plan to plan and from carrier to carrier. So we need to look at them all individually, but many plans explicitly are contraindicated from covering any gynecomastia surgery, regardless of the cause. Individual plans may cover in certain circumstances, and in adolescents, they typically want to see evidence of functional impairment. So that could be irritation, pain, or physical limitations. They usually want to see at least a grade 2, so in glandular enlargement that's extending beyond just the areolar borders. And in terms of duration, we know that a lot of pubertal gynecomastia does go away, and it's because it's such a common condition. The vast majority of gynecomastia does resolve in a few years after onset. So they typically want to see that it's been present for a long time. And if it is present for a long time, that we are classically trained to think that the presence of the gynecomastia for longer than a year can lead to a fibrous conversion of that tissue that makes it less likely to completely recede. So we are looking also for longer duration gynecomastia that may not completely resolve just with the progression of puberty. Some medications can be associated with gynecomastia, so we want to make sure that any of those are stopped as well to reduce any medication influences. And then obviously they want to make sure that this isn't related to a different condition. So a full normal laboratory workup is typically required. And this may be done by an endocrinologist, but it also could be done by a primary doctor with a good physical exam along with it. So just one quick slide about some other conditions that we see, or two quick slides. It's more rare to be seen, but it is one of the more complicated things that we take care of. So tuberous breast deformity is a congenital abnormality that usually doesn't manifest itself until our children start to go through puberty and have breast development, where we start to see that particularly the inferior portion of the breast, it has a constriction that is impeding breast growth. And this comes in a variety of severities and can involve just the medial aspect of the lower breast, or all the way up to involving basically the entire breast, basically breast hypoplasia. And I saw a child recently that had a bilateral case, pretty significant asymmetry. And there's really good literature to show that even in adult patients that are presenting for potential breast cosmetic surgery, that there's rates as high as 25% of patients have some form of this type of deformity. So this again would really start to manifest itself after the beginning of puberty, where breasts start to develop, and maybe you would see breast asymmetry or particularly changes in the shape of the breast on the inferior aspect of the breast, where you're not seeing that normal release and ptosis of that glandular tissue as it's growing out from the chest. And then again, even less common, we also take care of patients with Perelman syndrome. So Perelman syndrome is a constellation of findings, usually involving syndactyly as well. But what we notice on the chest is usually either hypoplasia or an absent breast on the affected side, and an absence of a portion of the pectoralis muscle on that side. So what's classically seen is this disturbance in the anterior portion of the axilla. So you can see in that middle patient on his right hand side, you don't see that normal contour of where the pec muscle is coming up to meet the shoulder, and you have instead that curve that's heading up and in towards the sternum. That is demonstrated from the absence of that muscle. And women with Perelman syndrome also often will have a very little breast tissue development, or even none at all. They may be missing their nipple areola complex as well. So these women usually require reconstructive surgery of a variety of different types. But the reason I'm mentioning this now is because a lot of these surgeries sometimes can be planned in a way to coincide with their what would be their normal breast development, so that they can have a better psychosocial response to this condition as we move forward with a multi-stage reconstruction. And sometimes what we'll do is we'll place a temporary device that we can inflate almost like a tissue expander or a temporary breast implant on the affected side that we can gradually increase over time as their unaffected breast grows, to provide more symmetry while we are waiting for their development to be complete for their final reconstruction. So I just mentioned these two conditions because they are conditions that you should probably be referring the patients to us as soon as they're identified, so that we can have an opportunity to do these types of reconstructions that kind of grow with the patients as well, just to have that aspect of the psychosocial functioning during such an important time of adolescence. So just to summarize what I've kind of said today, the main things for you guys going forward is to think about the conservative things that you can do for your patients with macromastia. Maybe they're not ready to see us yet, or maybe they're a little young. So you can always start with things like physical therapy, recommending nice supportive devices, and some of those more conservative measures. Most patients with gynecomastia really just need reassurance and monitoring in the early phases of pubertal gynecomastia. But also, if it's really something that either seems more extreme or that it's been present for a while, there's always a possibility that you could do some of that lab workup prior to sending the patients to see us as well, or even an endocrinology referral if you think that that's warranted based on the individual patient. And again, as I just mentioned, some of those more rare congenital abnormalities really have an indication to start with a multi-stage reconstruction really around the time of breast development. So if those patients get into our office sooner rather than later, we have some more options that might help them with their psychosocial adjustment over time. So that is all that I have today. And I just wanted to thank you guys for taking some time out of your lunch break to go through this stuff with me. I'm happy to answer any questions. And again, I will be hopefully starting to see patients in Skokie beginning in January of the new year. And thanks for your time. Thanks for all your help, Chad. And I have time, so if you have questions, I'd happy to answer.
Well, this is great. So if anybody wants to ask a question, feel free. There's not a lot of you on right now, so go ahead and unmute you. I know there's many of you who are watching right now in your break rooms, sharing a computer screen. So if that's the case, go ahead and type it in. But if we don't see anything, then we'll go ahead and conclude our session. And just a reminder, I'll be sending the link out to the session to everybody. Feel free to share with your staff and teammates, because we would love to get the word out of our Dr. McGrath here, because we are very excited that you're here with us today. So thank you.
Thank you so much.
Okay. Well, everybody have a great day. And just for many of you, I see a lot of regular faces here and names on the meeting. We'll be changing up some of our times here. We're going to go to a 7:30 in the morning slot for our next few meetings and see how that works for everybody. So Again, thank you and have a wonderful day. Bye-bye.
Thank you. Stay safe.